and Gynecology at Women and Parker. So the topic of discussion is cervical cancer and screening and prevention. So I am so honored today and delighted because of the guest that we have who is taking us through this session. He is none other than our renowned gyne oncologist, cervical cancer coordinator from the Ministry of Health, Dr. Paul Kamfa. We would like to welcome you to this session this afternoon. Honored to be next to you. So delighted because he is actually one of my mentors. And I'm honored, sir. Welcome to this platform. Otherwise, the stage is to you, sir. Please feel free to greet the audience. And please, wherever you're tuning from in the chat box, hit us up, let us know where you're tuning out from. I can see Lewanika General Hospital represented here. Please just let us know from the chat box where you are tuning in. If there are other people maybe you forgot to invite, make sure that they do not miss on this information that we are about to get this afternoon. Dr. Kamfa, welcome to the Echo session. Please, sir, the floor is yours.
Thank you so much, Mbiza, and good afternoon, everyone who has joined us on the call.
Okay. So there you have it. Get a pen, get a paper, find somewhere where to scribble up.
Good afternoon once more. It's good to see quite a good number of you who have joined us on the call. And like what Mbiza has mentioned, we want to look at cervical cancer, the screening aspect, then we go into the prevention. In fact, this time we have started talking about elimination. Today's objectives, we want first to discuss who, how often, and when to screen for cervical cancer. Then we look at 3 different platforms that we normally use for cervical cancer screening. Then, of course, we go into the benefits and limitations of screen and treat approach as opposed to screen, triage, and treat. Then we shall end today's didactic when we look at primary, secondary, and tertiary prevention of cervical cancer. So these will be the objectives.
Okay, so we will start first by getting to our polls. According to WHO, what should be the screening interval? What should be the screening interval between HPV DNA detection as a primary screening test among women living with HIV? According to WHO, what should be the screening interval when using the HPV DNA detection as the primary screening test among women living with HIV? A, 1 to 2 years, B, 2 to 3 years, C, 3 to 5 years, or D, 5 to 10 years. So we shall now share the polls. Please feel free to pick one of those as you think is the right answer. Okay, the polls are open. Okay, so we'll be ending the poll soon. Please make sure you type in which answer you think is correct. So we're at a countdown of 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And we are closing the poll. Okay, so 49% picked A, 35% picked B, 10% picked C, and 5% picked D. Okay.
Thank you so much for those answers. We shall go into HPV DNA according to WHO. We shall also tackle the HPV DNA according to the Zambian guidelines. First, we want to start by who are we supposed to screen? Of course, if you look at Zambia, we want to screen all the women who are between 25 to 59 years old. And this has to depend on the platform. If you look at the centers where you are, sometimes it's written that you need to screen the women who are between 25 to 49 years old. Reason being is that the screening modality which is being used that time, it's VIA. And we know VIA is not very good to be used in those women where we cannot see the transformation zone. Reason being is that after 49 years old, when some women are reaching 50 years old, you are going to find that the transformation zone is going to recede, and it will be very difficult for you to see it. And remember, the transformation zone is the area where pre-cancers and cancer start from. So when you screen that woman, you are going to think that she is VIA negative. But this has been extended to 59 years old, taking into consideration HPV testing. And we require to screen our women very regular. And this is both for those who are living with HIV and the general population. When we are using VIA, you are going to find that the algorithm tells you that you need to screen those who are living with HIV every 2 years, and those who are HIV negative every 3 years. That's the general population. When should we screen these, especially when we are using VIA? It can be done at any point in menstrual cycle. If the woman is having heavy periods, we want to reschedule that screening. Reason being is that we are not going to see the cervix clearly. And if a woman has got a heavy cervical infection, what we do is we have to reschedule. We just have to give her antibiotics. Of course, the recent sexual intercourse is not going to affect screening when you are using VIA. If a woman has got advanced pregnancy, you also have to reschedule. We have talked about the women who are living with HIV/AIDS as a focus for us. Why? First of all, the women who are living with HIV/AIDS, they are 5 to 6 times at risk of developing cervical cancer. Because they are 5 to 6 times developing cervical cancer, that's the more reason why we want to focus on them. Remember, these women have got a higher prevalence of HPV. And they also have a higher incidence of HPV infection. At the same time, when we're talking about the HPV being persistent in their body, it's quite high as compared to those who are HIV negative. Again, for these women, the likelihood of getting multiple HPV subtypes is quite high. And in fact, those who are living with HIV/AIDS, they get cervical cancer at a young age, and it develops more quickly as compared to those who are living who are HIV negative. In fact, if you look at some statistics which were taken some time back, 40% of those who are younger than 30 years old are likely to get cervical cancer in Zambia. And of course, the other reason is that cervical precancer and cervical cancer, it recurs more often and within a very short period in the women who are living with HIV/AIDS. And that's the reason why we want to focus. If you look at this, it is trying now to bring to our attention the screening modality, that of HPV. And this is according now to WHO. So on the left side, you are going to see for the general population. On the other side, it's for those women who are living with HIV. So for the general population, they are the ones where we have to do screen and treat or screen, triage, and treat. And when we are using HPV DNA, we have to start at 30 years old. Remember, Zambia, we said 25 years old, but for WHO, you have to start at 30 years old and you should stop at 50 years old, only when you have seen that the woman has had 2 negative screening results. But those who are outside this bracket, the ones who are between 50 and 65 years old, and they have never been screened, they should also prioritize. So for the general population, the screening has to be every 5 to 10 years. Those who are HIV negative, you are using HPV, 5 to 10 years old. For those who are living with HIV and you are using HPV, it is 3 to 5 years old. That's the screening interval. And the period when you have to start the screening is supposed to be 25 years old, as opposed to those who are HIV negative, where you have to start at 30 years old. How about if we look at Zambia? What are the differences that are there from what we have learned about WHO? So for Zambia, for the general population, even for those who are HIV/AIDS, both we have to start at 25 years old. Then we have to stop at 59 years old after 2 consecutive negative screening tests. But remember, for us, those who are outside that bracket, and it means 60 to 65 years old who haven't been screened, we can still screen them. But for the general population, for HPV DNA, it's every after 5 years, every after 5 years. But for those who are living with HIV, every after 3 years. That's for Zambia. This is trying to bring again to your attention when we are using BIA as a primary screening test, and it is what you have always been using. For those that we know they are HIV negative, those we want to rescreen them after 3 years. For those who are HIV positive, we want to rescreen them after 2 years. The only change which is going to be to this algorithm when the guidelines come out will be both the HIV negative and the HIV positive will be rescreened every after 3 years. But in the meantime, keep what you have been doing, HIV positive every after 2 years, those HIV negative every after 3 years. Next. For HPV DNA, I think I had to mention saying we need to screen them, those who are living with HIV/AIDS every after 3 years, those who are HIV negative every after 5 years. So this is regarding the HPV DNA, both for the general population and the women who are living with HIV. Yes. But if you look at those who are HIV negative, if you remember what we mentioned, those, when we are using HPV DNA, then we can do the screen and treat, and we can also do the screen, triage, and treat. But for those who are living with HIV, we do not want to be doing the screen and treat. We want to be doing the screen, triage, and treat. This is with regard to HPV DNA. And of course, we have to rescreen them every after years, and this has to be with the HPV test. Next.
Okay, so we move on to the second poll. For those who are still logging in, welcome to the ECHO session. Today's topic of discussion is cervical cancer screening and prevention. Your host today is Dr. Christabel Mbiza from Obs and Gyn. And the speaker who's just come just before me is Dr. Paul Kamfwa. He's a gynecologist, a coordinator for cervical cancer at Ministry of Health. So we are on poll number 2. What is the current recommendation by WHO as the primary screening test and treatment approaches among both the general population of women and the women living with HIV? A, VRA and VILI. B, cytology. C, colposcopy. D, HPV DNA. So we can open the poll. Great responses coming up. Seems learning is taking place. So we just have a minute before we close the polls. Please make sure that you have given us the answer you think is best suited for the question above. What is the current recommendation by WHO as a primary screening test and treatment approaches among both the general population of women and the women living with HIV? So 10, 9, 8, 7, 6, 5, we're closing the poll. 6, 5 again, 4, 3, 2, 1, and we ended the poll. Thank you so much for the participation. So the response to the question in terms of percentage is 54 voted for A, 3% thought it was B, cytology, 2% thought it was colposcopy, and we had 44% who thought it was DNA HPV. Okay. So we will move on to our presentation.
If the world is going to be on the path of cervical cancer elimination, WHO has stated that 70% of women are supposed to be screened with a very efficacious test, and this is when they are 35 and when they are 45. So when you start talking about the test, which is very efficacious, and which has got a very high sensitivity, this is when we talk about HPV DNA. So HPV DNA is the primary screening test. When you look at HPV DNA as compared to these other tests, VIA stands for visual inspection with acetic acid. V-line is visual inspection with Lugos iodine. And when you bring them head to head, VIA and HPV DNA, you are going to find that HPV DNA is more sensitive as compared to VIA. And that's the reason why WHO has said that the best is to use the screening test, which has got a high sensitivity, in this case, HPV DNA. Let's look at 3 different platforms that we have in Zambia in as far as screening of cervical cancer is concerned. The one which we have always been using since 2006 and which we shall still continue using until all the sites start using HPV as the primary screening test is VIA. So when you look at VIA, it is a nurse-led platform. And it uses vinegar, the same vinegar that we get in the supermarkets, but in the concentration of 3 to 5%. And we put it on the cervix with or without magnification. And if there is a problem, what we see is acetal white lesion when there is a reaction on the cervix. In other words, VIA helps us to detect the cell changes on the cervix. And it is a very inexpensive platform. The only problem which is associated with VIA, or I mean, the biggest problem is its subjectivity in the interpretation. At the same time, there are also issues when it comes to quality control and quality assurance. But the beauty is that it does not require laboratory services. And if you look at the top picture, it is trying to show us what we normally see when we are doing VIA. The normal squamous epithelium looks pink, and when we start seeing something closer to the os which looks red, that is the columnar epithelium, and it is because of the underlying stroma. That's why the appearance is red. When you look at the middle picture, which is at the bottom, we are seeing what we call acetal white lesion. That is after the application of vinegar or acetic acid. And that has occurred because of the coagulation of the cellular proteins. And we all understand that HPV-infected cells, they are very active and they contain more proteins. As a result, they cause that opaque that we see. So this has been one of the most popular platforms that we have always been using since 2006. And we have mentioned as a country, we shall continue using it until all the centers are going to start doing HPV testing. So this is what HPV testing is all about. When you look at HPV testing, there is what we call provider collection, and there is what we call self-collection. So on the left side, you are able to see provider collection, and on the other side, you can see self-collection. So when you look at HPV DNA, it detects the DNA in the vaginal or cervical smear. And this is the one that we as a country are going to be using as a primary screening test. And what it does is to detect the high-risk HPV. But when a woman has been told that she has got that high-risk HPV, it does not mean that she has got pre-cancer or she has got cancer. Reason being is that she's able to get rid of that HPV DNA depending on her immunity. 80% when they reach 1 year, 6 months, and 95% at 2 years. If the immune system is very good, they are able to get rid of that HPV. And the collection is what is shown on the left side. And after the collection of the smear has been done, it is then transported to the lab and it is preserved. Then the sample can even be preserved up to 4 degrees Celsius and 3 months at -20 degrees. When in your locality there is HPV DNA, please have a look at the expiry date. We do not want to use the test when it has expired. The last screening modality, which is normally used in the private sector, is cytology. This is liquid-based cytology or pap smear. What it does is to identify the atypical cells on the cervix, and this is through the preparation and interpretation on the slide. That's the pap smear. But when you look at liquid-based cytology, it is quite sophisticated in that there is creation of the slides from those liquid specimens. So if you look at our country, we have said that we use 3 types of modalities. The first, which is frequently used, is VIA, standing for visual inspection using acetic acid. And the second one is HPV testing, and the last one is cytology, in this case using liquid-based or pap smear. Next.
Okay. All right. So now we take to the polls. In a screen and test approach, the decision to treat is made when A, both the primary test and the triage test are positive. B, both the primary test and the triage test are negative. C, the primary test is negative and the triage is positive. D, the primary test is positive.
And this of sharing. They're sharing the photo. So
So the question is, in a screen and treat approach, the decision to treat is made when A, both the primary test and the triage test are positive. B, both the primary test and the triage test are negative. C, the primary test is negative and the triage test is positive. Or D, the primary test is positive. Okay, so we'll be closing the poll soon. Make sure you pick one. It's an SBA, so just one answer. If you try and place two, it will not accept. All right, so we are ending the poll. So 51% thought A was the right answer. 1% thought B was the right answer. 3% thought C was the right answer. And 45% thought D was the correct answer.
Thank you so much for those answers. So there are two approaches. There are two approaches in as far as cervical cancer screening and treatment is concerned. The first approach is screen and treat. The second approach is screen, triage, and treat. So one approach, screen and treat. The other approach, screen, triage, and treat. So when you look at screen and treat approach, it uses a point of care screening test, such as VIA. So this is where we identify that the woman has got the acetoid lesion, and we go on to treat. There is no second test that should be done. So when we are talking about screen and treat approach, it is purely based on a positive primary screening test alone, just on a positive primary screening. There is nothing like triaging, because it is just a screen and treat. Nothing like triaging. It is just on positive primary tests. And normally what happens is that those women who are going to screen positive, they require to be treated without histological diagnosis. And you know what happens? Like in VIA, we can either ablate them. In the ablation, we use either coagulation, or we either use thermoablation or coagulation. Or we can excise, in this case, using the lip. It can either be done in a single visit or in multiple visits. That's the screen and treat approach. You know, the beauty with the screen and treat approach, it removes the barriers of development of a large-scale cervical cancer prevention initiative in a resource-strained country like ours. Next. However, when you look at it, it has got some benefits and some limitations. The benefits are that it does not require any laboratory. At the same time, what is normally used is not very expensive equipment, and it is affordable. And the beauty is that there is reduction in the loss to follow-up, and it does not even require trained doctors. The nurses are able to do that. But the limitation is that it doesn't give us histopathology. At the same time, it's a bit of a problem when we are talking about women living with HIV and we want to use triaging.
Okay, so we are back. We now take to the polls. We have learned about the primary screening, so we are learning a lot. For those that are still joining, you are most welcome to this echo session, cervical cancer screening and prevention. So, secondary cervical cancer prevention focuses on the following, except A, screening, B, treatment, C, vaccination. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. The response on this one is coming very fast. It's like hotcakes. All right, so we'll be closing the poll in less than a minute. All right, we are ending the poll now. Thank you so much for your participation. Responses that we've gotten. So 14% thought it was A, 30% thought it was B, treatment, and 55% thought it was C, vaccination.
So, very, very good responses from you, the group. So when we are talking about cervical cancer prevention, there are three pillars. There is primary prevention, there is secondary prevention, then there is tertiary prevention. When we are talking about primary prevention, it means we do not want this woman or this girl to get HPV infection. You do not want somebody to get HPV infection. So how do we do it when we do not want someone to get HPV infection? This is mainly through HPV vaccination. So one of the hallmarks of primary prevention in cervical cancer is HPV vaccination. And when we start talking about secondary prevention, in secondary prevention, this is when we talk about screening. So when we are doing all those screening with VIA, with HPV testing, even with cytology, what we are doing is secondary prevention. And when we find that someone has got a pre-cancer, before they develop invasive cancer, that is secondary prevention. So when you have been asked about secondary prevention, it's mostly screening and the treatment of those pre-cancer lesions before they could go into invasive cancer. How about a situation when we have seen that somebody has invasive cancer according to that stage, but we want to prevent the death, or we want to improve the survival, or we want to ensure that that person has got a quality of life? That becomes secondary prevention. In other words, when you start giving radiotherapy, chemotherapy, targeted therapy, or you are doing everything to improve the quality of life of that person who already has cancer, then that is tertiary prevention. Thanks. So if you look at that, it is trying to show you the life course approach to cervical cancer intervention. When you talk about primary prevention, the thing that we talked about is HPV vaccination. And in Zambia, you have been giving our girls who are 14 years and 15 years the HPV vaccine. And we have been doing quite well. That is a form of primary prevention. The other form is health information and warnings about tobacco or sex education, and also condom promotion. When we talk about secondary prevention, this is where we want screening with a high performance test. And an example of a high performance test, HPV test. And when we find that the woman has got a lesion, we quickly treat those pre-cancer lesions. And we talked about tertiary prevention, surgery, radiotherapy, chemotherapy, and palliative care. So what have we learned this afternoon, or what is the take-home message? First of all, if you look at our country, we have got a robust screening program, which started in 2006. And we have been using VIA as a primary screening test. But from 2019, from 2021, we adopted the use of HPV as a primary screening test. So VIA is going to be running alongside HPV DNA until all the centers are going to start using HPV. Why are we trying to shift from VIA to HPV? Reason being, HPV has got a high sensitivity and specificity. Then, what are the methods that we can also use in the approaches? There is a screen and treat, and there is also screen, triage, and treat. And for us in the country, the screening is from 25 to 59 years old, depending on the platform. Of course, there are three pillars which are very, very important, which can help us in the elimination of cervical cancer, particularly the first pillar, which is talking about vaccination. And we want to vaccinate 90% of our girls. Please, please, where you are, during the Every Child Health Week, there is an announcement which comes saying that those who are 14, 15 years old, they should receive the HPV vaccine. Make sure that you encourage our daughters, our nieces to go for vaccination, because we want to eliminate cervical cancer. And please encourage, again, our women, our mothers to go for cervical cancer screening, particularly those who are HIV or those who are living with HIV. Reason being is that I mentioned those who are living with HIV, they are 5 times at risk of developing cervical cancer. We don't want our women to be dying from cervical cancer, and yet we know cervical cancer is purely a preventable disease. Why should we allow our women to be dying from a disease which we can prevent, yet they are surviving the HIV? Remember, a long time ago, people were fearing when they have HIV, but this time they are fearing when they have a preventable disease, which is cervical cancer. So altogether, if we work towards vaccination, towards screening, we are going to ensure that we eliminate cervical cancer. Thank you so much for listening, and have a wonderful day. Of course, I acknowledge our implementing partners and WHO for those algorithms that we have used, and also Ministry of Health.
Thank you so much, Dr. Kamfa, for that learning session. For those that do not know, the speaker who has just come from speaking, he is Dr. Paul Kamfa, renowned gynecologist, cervical cancer coordinator from the Ministry of Health. We cannot thank you enough for taking us through this session. So Your host today is Dr. Mbiza Christopher from the Department of Obstetrics and Gynecology based at Women and Newborn Hospital, UTH, Lusaka. So we will now go back to the repo. Let's run through the questions again, and let's see how learning has taken place. Okay. Oh, okay. So we are now on the first poll. According to WHO, what should be the screening interval when using HPV DNA detection as a primary screening test among women living with HIV? A, 1 to 2 years, B, 2 to 3 years, C, 3 to 5 years, D, 5 to 10 years. So let's keep those answers coming, please. Okay, so thank you very much. Now we'll end the poll. So back to the question. According to WHO, what should be the screening interval when using HPV DNA detection as a primary screening test among women living with HIV?
Thank you so much for those responses. Of course, the answer is C. So for those who are HIV positive and we are using HPV DNA, the interval is supposed to be 3 to 5 years. 3 to 5 years. Those who are HIV negative, 5 to 10 years. It's quite different from 2 to 3 years. So the answer is C, 3 to 5 years.
Okay. So we move on to the second poll. Okay, so we are on the second poll. What is the current recommendation by WHO as a primary screening test and treatment approaches among both the general population of women and women living with HIV? What is the current recommendation by WHO as a primary screening test and treatment approaches among both the general population of women and women living with HIV? So A, VIA and VILI, B, cytology, C, colposcopy, and D, HPV DNA. So Dr. Kamfo has deliberated on making sure that we are equipped with knowledge. Please, let's appreciate him by making sure that we answer these single best 100%. Okay, so thank you so much. I will end the poll.
Thank you so much. Of course, you have it there, 79%. It's HPV DNA.
All right, thank you so much. So we move on to our third poll. At least you have made his afternoon. He's smiling that we all got 79%. Is that an A+ for them? Okay, so we move on to the third poll. In a screen and treat approach, the decision is made when In a screen and treat approach, the decision to treat is made when A, both the primary test and the triage test are positive. B, both the primary test and the triage test are negative. C, the primary test is negative and the triage test is positive. And D, the primary test is positive. So when do we do the screen and taste approach decision? Okay, we shall be closing the polls now.
Thank you so much. Of course, the 83% you have it. It is the primary test which should be positive. Remember, it is screen and treat approach. We were not even talking about triaging. We were just talking about screen and treat, not the approach of triaging. So the 83%, you are correct. It is supposed to be the primary test to be positive. Thank you so much.
All right. So we are now moving to poll number 4. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. All right, keep those responses coming. We are now closing the poll. Thank you so much for your participation.
Thank you so much. Again, the 77% you have it. The except is vaccination. Vaccination is primary prevention. But when we are talking about screening and treatment of the pre-cancer, that is secondary prevention. Thank you so much for listening.
All right. Thank you so much for participating. So now we move on to our second session, which will be question and discussion. Please take note that even though we have Dr. Kamfwa here having done the presentation, we also have a group of experts on this chart. We've got Dr. Funda, Dr. Munalula, Dr. Chituo, Dr. Kaunga, and Dr. Samson Chisele. So even as people are asking the question, we will pick in any of these experts to make sure that your questions are answered. So, okay, so just before we move on to the question, can we just quickly do the case presentation by Gloria so that we sum it up with a session of Q&A? Okay, so Gloria from Lewanika General Hospital in Western Province, the floor is yours.
Hello, good afternoon. Hello.
Hello, Gloria, good afternoon. We can hear you.
Good afternoon, madam. Kind of asking if you can share the case on the screen. Okay. Okay, good afternoon, everyone. Hello.
Good afternoon.
Hello. Good afternoon, thank you.
Okay.
Good afternoon.
Hello. Hello. Good afternoon, everyone.
Good afternoon.
Gloria,
We can hear you.
from Lewanika General Hospital, Mongu Lewanika. The case which I'm going to present is for our client ID number, which is NC, female 48 of Kaoma. This client came with complaint of 1 month history of PV bleeding. She used to change 4 pads per day. She had complaint also of lower abdominal pains and backache associated with the headache and dizziness. There was no history of foul smearing discharge. Then ROS, it was non-revealing. History of cervical cancer screening. She started a screening in 2013. Her second visit, it was in 2015. Third visit, it was in 2018 at Luena Barracks. All the results were very negative. The suspicious results came in March and April, that was 2022 at Kaoma District Hospital. There was no history of biopsy done. Then she developed PV bleeding in August 2022. Then she referred herself to Lewanika General Hospital. VIA looked normal apart from unusual vessels. Biopsy was done. Past medical history, she's hypertensive, no history of HIV, no history of DM, no history of asthma, but she had the history of appendectomy. That was in August 2015. On social economics, no history of smoking or alcohol intake. She's married. She has 5 children. The last delivery, it was in 2014. On physical examination, which was done in September 2022, general condition, she looked stable. She had para +1, a fib on touch, no jaundice, no lymph nodes. Then on vital signs, blood pressure, it was 120/65. Pulse, it was 68. Respiration or temperature, it was 36 degrees Celsius. Respiration, it was 18 beats per minute. On chest examination, CVS, abdomen, and it was normal. Then on VE examination, it was normal. VIA picture, it's on the next slide. So it was very positive. Then abnormal blood vessels on the upper lip, planning towards the punch biopsy. Can go to the next slide. Then on investigations, which were done, the date of collection, the first one, which was 28 December 2022, we had collected blood for full blood count, of which the HB was 9.2 or 9.0, platelets were 60. Then WCC, it was 1.31. ALT, it was 16.5. AST, it was 31.5. Then on cervical biopsy, which was done on 29 September 2022, it came out CIN2 with the active and the chronic cervicitis. Then on 21st October 2022, biopsy, we repeated the lip. Then the results came out as adenocarcinoma. Then on scan, it reviewed cervical mass noted. That was on the 21st October 2022. Can go to the next slide. Our questions are, what are the limitations of VIA screening methods? Question number 1. Then question number 2 is VIA suitable for all types of cervix? If not, what option do we have? Question number 3, how do we prevent this situation where a woman initially has VIA negative results, then later turns out to be a cancer positive? Thank you very much.
Okay, thank you so much for the presentation, Gloria. So we will look for the experts. All right, so we'll have the network.
So the network, what do they think about? The network, what do they think about?
Okay, so we are back to the network. Let's just get a feedback. Okay, so we post to the network for any questions, clarifications.
Oh, now we got him today. I'll come from the second.
There's a hand from Vernon, Southern Province.
Okay, so there's a hand from Vernon, Southern Province.
Yes, so good afternoon. So I didn't get your submission clearly. I'm not too sure if you want us to attempt the questions that have been shared on the screen, because I think we're able to see the first question, which says, what are the limitations of VIA screening method? So I'm not too sure if you're allowed to attempt.
You can go ahead and attempt.
Okay, so from the case, we can see that I think the client received quite a number of screening services. I think she was quite adherent to the stipulated timelines. I think, am I audible? So you can see that I think the woman was screened using VIA, but looking at the age, which is 48, this is a woman probably who is in a post-menopausal period or age, and hence at times it may be difficult to appreciate the transformation zone. So you may do your VIA, but you may have limitations in terms of getting to appreciate the transformation zone, which is very key when you are doing a VIA. So I'm thinking this could be one of the limitations in this case. Maybe I end on question 1, so that others maybe may chip in as well. I submit.
Thank you so much. Okay. All right, so Amukombwe, you can unmute yourself.
Sure. Good afternoon. Thank you. Arthur Mkombo here from Right to Care Zambia in Mokula. Okay, so I cannot agree with Vernon on question 1. So question 2 and 3. Let me go to question 3, and then I think in line with question 3, I'm also going to pose in my question. So, so how do we prevent situations where a woman initially was VIA negative and then they later on turn out to be cervical cancer positive? This is as good as saying, how do you prevent someone from being HIV negative to being HIV positive? Okay, from the way this question is going and the history that has been given to us. So definitely I'm dealing with the HIV positive population. Pardon me, Chair, and Dr. Kamfa, I'm more biased to the HIV positive. So definitely, I think you did mention on how the algorithm is for testing, which is obviously applicable to this question. Now, so to answer this question, yeah, definitely any woman can be negative for cervical cancer at any point, but definitely because of the exposures and because of what they are susceptible to, what they are made to go through. This is an HIV negative woman from history. So possibly if they turn out to be HIV positive, their risks, obviously, of turning cervical cancer screening positive, either to HPV or to VIA, are very high, because HIV positive women are 5 times higher at risk than those HIV negative. So unless there's more to this question, maybe the Lewanika Gloria can clarify more. So we have to prevent this woman from turning out to be HIV positive, and then she has to be treated from the bleeding that she has, because definitely that is sitting against her pH levels in the cervix, which obviously may suscept her to actually getting a cervical cancer. You can mute your mic. Okay, thank you. So this may expose the woman, just the bleeding itself, uncontrolled bleeding, may also expose her probably to having cervical cancer because of the pH that could be compromised. So my question, Dr. Kamfa, is this, I think it didn't come out very clearly. So for the HIV positive women, you know, we screen, we triage, and then we treat. So please just maybe briefly run us through. So here's a woman who we have screened with an HPV swab. They are positive. I'm talking about HIV positive women. We screen with an HPV swab, they are positive. What's next? If the HPV swab is negative, definitely we know that we can screen them again after 3 to 5 years. Number 2, is VIA confirmatory enough as part of triage? So maybe just break down the triage aspect. So those are the 2 questions. What do you mean when you say triage? Maybe just break it down so that everyone can be able to follow it through, as well as the HPV in an HIV positive woman. So what's next? Because we can't test and treat in positive women, we have to triage. So maybe your guidance over that. Over.
Okay. All right. Dr. Tsele.
Thank you. Dr. Kamfa and Isa, the team for the meeting. Yeah, so let me begin perhaps with the last question, which is that what do we do with women that have been screened with HPV positive tests, who are screened and they turn out to be positive and are also living with HIV. So the guidance, the current guidance from WHO is that women that are living with HIV and AIDS should not have a screen and treat with HPV. The reason is that, and I think this has been explained earlier, that women with HIV, living with HIV, have a much higher risk of having infection with HPV. And therefore, when you screen them with HPV tests, you are also likely to have a high number of these women whose test is not necessarily true, in that the false positives are likely to be higher. And what the screen, triage, and treat modality, which Dr. Kamfa spoke about, does is that it reduces the risk of overtreatment. Okay, so when you look at the absolute numbers of women that will be treated that are HIV positive, it will be much higher compared to the number of women who will be treated and yet will be overtreated. Perhaps the better terminology is overtreatment. So in HIV negative women, the number of women women who are HIV negative that will be overtreated is likely to be lower than the number of women who are HIV positive. And so that is why WHO recommends that in order to reduce this overtreatment, we should in fact do a triage. And what is the triage? Triage means that you go for any of the other existing methods, including VIA. So you do HPV tests. When it's positive, you actually do VIA to triage, and then you're going to treat based on the VIA tests. Or the other option would be that you do HPV test and it's positive. Because this woman is HIV negative, you go ahead and do, let's say, cytology, which has been mentioned. In fact, there are a few others that I think Dr. Comfort didn't talk about because that's not the focus of this discussion. There is also something called genotyping, where you try and get another HPV test, which is going to be more specific to the, to the high risk, the 16 and 18 subtypes, which are more, associated with cervical cancer. Indeed, in some instances, you can actually do HPV tests, and once it's positive, you go straight into doing a colposcopy, and then from colposcopy you go ahead and treat. So that is basically what the options would be for these women. I'm not so sure that I heard I can't remember the first question, but I agree with the response given to the first question here with regard with regard some of the limitations for the VIA, which is one that it has a very low specificity. The VIA test has a very, very low specificity. It's basically user dependent. So those who have had more experience with the VIAs are more likely to get, accurate results perhaps than those that have, less experience. That's one. But number two also is that it is not applicable in women that, have got a type of cervix called, transformation zone called type 3. A type 3 transformation zone is where, the junction, if you will, between the squamous and the columnar junction, the new squamocolumnar junction, so to speak, is not completely visible. And because that junction is sort of a proxy to what you call the transformation zone. So if you're able to see that junction, there's a good chance that you will also be able to see the transformation zone. But in some women, and I think Dr. Kampa mentioned this, and one other speaker mentioned that in women who are approaching menopause and so on, this transformation zone recedes. It goes back into the endocervical canal, so to speak. And because most of the cervical cancers will start in the transformation zone, it's quite possible that you apply acetic acid on the cervix, and you said that the result is negative because you haven't seen any acetal white lesion, and yet the acetal white lesion is actually, hidden within the endocervical canal, and that is why the World Health Organization cervical cancer elimination strategy is to try as quickly as possible to move to HPV testing. Quickly as possible, move to HPV testing. Of course, vaccination, as already mentioned, is critical. That's the primary one. Vaccinate up to 90% of girls below 15, and then, of course, go to screening using a high performance test, which in this case is the HPV test, and of course, about treatment. Yeah, so I think that would be my take. Chair. Thank you very much.
All right. Thank you for that answer. There's a hand.
Thank you, Chair. This is Dr. Chituo. I just wanted to contribute to question number 3. I noticed that the woman had previously been screened about 4 years before. And I just wanted to reiterate the importance of the frequency of screening. The guidelines have been given to us, And for a woman coming from the general population, the screening frequency should be about 3 years. But for her, it was about 4. And probably the facility needs to strengthen the health literacy amongst the women that they see and stress on the importance of the screening frequency. And now those periods are given for a reason. And usually if a woman has got HPV, they can be cleared within a particular period of time. But since they're using VIA, one would not know whether one has cleared any infection that they might have. Additionally, this was a woman who initially screened HIV negative. This was a missed opportunity. If a woman comes back with a condition that is AIDS defining or that's AIDS defining, it's an opportunity to also test for HIV, and also get further history on whether she is high risk or not. Initially, it was given that she has 5 children. I can't remember from the history that was given whether she's married or not. But it was an opportunity that was missed, where they could have tested the woman to find out if probably her status has changed, if maybe her risk has increased. So I just thought I should add that. But otherwise, I think the facility should continue to stress amongst the women that they see the importance of regular screening. Thank you.
Thank you very much for that contribution, Dr. Chituo. We have a hand raised. Felix Kasambele, could you unmute yourself?
I don't know if it was supposed to be me. I'm the one who was having the hand raised. Good, Sen. Can I go ahead?
Please go ahead.
Okay, thank you so much. I also noted from the case presentation that this woman was screened and suspected to have cervical cancer, to suspected cervical cancer, but there seemed to have been no action that was taken. I presume this is a facility that's not doing LEAP, so they couldn't collect a biopsy. So I want to understand, was she referred and then maybe she did not travel? Because what we are getting is that it's until the woman started having other problems, and then she did a self-transfer to the Lewanika General Hospital. So what could be the challenges surrounding issues to do with, for those facilities that are not providing LEAP services, or they can't collect a biopsy, ensuring that women reach facilities where they are providing that service. I also wanted to just make an addition to what Dr. Chituo did mention on how much we should be sensitive in ensuring that those that are reporting that they're HIV negative, but they come to our facilities. I think we need to see that we improve on our case identification, HIV case identification, even in cervical cancer screening. I'll just give an example of Eastern Province. We did just an analysis of our cervical cancer screening. So among the women that were screened with HPV, we found out that those that were coming out to have VAT positive were mostly amongst the women that were HIV negative, and they were grouped together with those that were with a non-HIV status. And our suspicion was that there could have been a possibility that amongst those that were HIV and non-status, there could be also some who have seroconverted, but maybe we did not just provide them with an opportunity to test. And what we have done now is to encourage that among our cervical cancer screening clinics, we are ensuring that we offer an HIV test to the women that are reporting to have a non-status, or they were tested long before the period that they should test. Thank you so much.
All right, thank you. So we also have, I don't know, Felix keep dropping out. Lewanika.
Hello, I just want to clarify some other questions which has been raised up concerning the HIV tests. This woman, she's HIV negative. It was recently done prior to screening. Then the other issue on the, whether it was self-referral or she came it was a self-referral. When she went to Kaoma Hospital, she was screened, then they suspected to be a positive VIA result, and they had to give antibiotics. When she went back post antibiotics, they still couldn't have a conclusive results for them to give to the client. That's how the client decided to come to Lewanika. By then, she even had the presentation of PV breeding. Thank you.
Oh, all right, thank you for that clarification. So we still have more experts. Dr. Mnalula, are you there? Dr. Funda.
Good afternoon. Thank you.
Good afternoon.
Yeah, I'm here. I'm just interested in question number 3. How do we prevent situations where a woman initially has VIA negative results, then later turns out to be cervical cancer positive? I think it's this comes down to our screening, the quality of the screening that we're performing. So if this lady presents as VIA negative, depending on menopausal status, if the transformation zone is type 3, it's unlikely to be VIA positive, even if she has invasive squamous cell carcinoma, that is endocervical, where the VIA won't be reached. So that's why when the WHO talks about the HPV test, it becomes a game changer in that we have these postmenopausal women that will be VIA negative, but 6 months down the line, they come back with very advanced cervical cancer because the transformation zone was type 3 or the cervical cancer was endocervical. So where the woman presents as VIA negative and you are very suspicious of the lesion, it is not wrong to ask for a second opinion from your colleague to have a look at the cervix, or you can refer to another facility where they could have give you a second opinion, because what we're screening is that we want to prevent these mothers coming in with advanced disease that is untreatable. So if we can have another facility giving us a second opinion, there's nothing wrong with that. So let's encourage interaction with the nearer facilities, although that can look at your cervix through the pictures from a camera that is taken while you're screening the patient. Thank you.
All right, thank you. So what is being echoed is that if we are not sure, there's no harm in asking for a second opinion, referring the patient. Any other questions? There's still question 2 in terms of just the case that we had to say, was VIA, is it a good tool for all cases? Jane Matambo.
Hello, good afternoon. I'm hoping that you can clearly hear me.
Yes,
so maybe thank you. Just as a contribution to the sentiments that have been said already by, especially the ones that have been mentioned by Dr. Funda, I think also we would also want to just emphasize on the quality of the pictures that we collect for these women. Yeah, so because when you get a good cervigram, which is I think most of us know what a cervigram is, which is a picture of a cervix, it's very easy to interpret what the result would be for that particular woman. But if the picture is hazy, you can't even tell what the result is. It's very possible that you can miss out on some of these conditions for these women. Even when they came out, so when they came out negative the other time, then the next time they pop up, they have full-blown cervical cancer. So it also,
No, I think she's just dropped off. Okay. So it seems we lost Jane there. So we just want to thank everyone for taking part in this session. Please feel free to ask any other questions through the chats in our WhatsApp group. And we just want to finally thank Dr. Kampwa for spending your afternoon with us, taking us through cervical cancer screening and prevention. We appreciate you, and we promise that we will use this information for the good, since we have been told this is a preventable disease, therefore women should not be dying from that. Let's encourage our female folk to screen. Let's encourage our sisters, cousins, so that at least we hold their hand and, make sure that they are healthy and know about what state their cervix is. Dr. Funda, you had something to say? I see your hand raised, Dr. Funda. Oh, okay.
Yes,
so
good afternoon.
Yes.
Just to encourage Team Lewanika that CN has been discharged, we encouraging them for sending patients that are amenable to surgery. So CN was operated on about 3 weeks ago. So today we saw her in the morning. She's been discharged, and should be seeing her for follow-up at Lewanika General. Congratulations for sending a patient that is amenable to surgery. Let's encourage patients to be sent for surgery that can be treated, even not, we don't require to go for chemoradiation, because this is a primary aim of screening, that we catch them all, we can treat them. Thank you.
All right.
Thank you so much.
All right, so that is the power of collaboration in patient management. Chibombo, I've seen that you want to be added to the WhatsApp group. We'll make sure that we do that. Otherwise, we just want to thank everyone for tuning in. From your host today, Dr. Christabel Mbiza, this is goodbye from me and Dr. Kamfwa. Thank you so much.
Thank you so much. For those questions, as long as they are in the chat box, the experts and I are going to respond to them. I know there are quite a good number you are mentioning. Where do we find the tertiary prevention, and where you haven't again understood on the algorithms? By the way, in a few months' time, most of the things are going to be clear on HPV DNA, because you are going to receive the guidelines. We haven't distributed those guidelines, but once you receive them, I think you won't even have problems in trying to comprehend. Thank you so much.
All right, thank you. So this is goodbye from us. Thank you so much for tuning in. Till the next session, bye.